we're going to spend some time talking about emergency cardiology, and I want to thank you all for being here. It's a bit unusual for us to be starting on an afternoon session, and how many of you just got off an airplane this morning? Raise up, okay, and I think most everyone probably ate lunch, so probably a lot of you are feeling a little bit like this, I would imagine, and by tomorrow morning, I suppose a lot of you may be like this, so hopefully that won't happen. I've been to Las Vegas too many times for conferences now, and a lot of people do overdo it, and so especially to the first-timers here and for the residents, I just want to give you a little advice about Vegas. It is a very unhealthy place to be in the first place. It's always in one of the least healthy cities in the country, and just to really highlight how unhealthy it can be to be in Vegas, I recently found out that there's actually a new hotel here in Las Vegas called left ventricular hypertrophy. That's, and I think just to get in, you need to have a blood pressure of at least 220 over 120 or so. And then to take it one step further, they even have a restaurant here called the Heart Attack Grill. This is not a joke, okay? There's a restaurant here called the Heart Attack Grill. You know, at the bottom it says, taste worth dying for. All of the waitresses dress up like nurses. I don't think they're actual nurses. And when they don't look like any of our nurses. But when you arrive, the waitresses will measure you and weigh you. And if you, top left, if you weigh over 350 pounds, you get to eat for free. Again, not a joke. And so you can see at the bottom some of the dishes that they have on the menu there. I've really wanted to go there just to buy a copy of the menu. Here's some of the things. Their signature dishes, the quadruple bypass burger, flatliner fries, deep fried in pure lard. This is a billboard. Top right, chocolate covered bacon. So they have breakfast food also. For people looking, and I don't know for sure. It's possible the waitresses are certified in ACLS. I'm not just joking. I'm not sure. So anyway, do your best to try to stay healthy. And if anybody does go there, hopefully, number one, you'll make it back. But if you do, get a copy of the menu. There have been a few people that have actually died in the restaurant. And what do you think happens every time somebody dies and it makes the news? What do you think happens to business? It skyrockets, of course, this crazy society that we have. Okay, so anyway, let's talk about some healthy issues in emergency cardiology. This is a little outline, and I'm going to start out by telling you what we're not going to talk about. Because what I try to do with this talk is not talk about things that many other speakers are going to focus on. There's going to be other speakers at the conference that talk about resuscitation, cardiac arrest, post-arrest care, AFib, and some of the ACS treatment updates and syncope. So this is not what I'm going to talk about for the next hour. I want to try to fill in some of the gaps that you might not hear elsewhere. And so I looked at the list of other speakers and I thought, well, all there is left is electrocardiography. Great. But apparently there is some other stuff that we will talk about. Mostly we're going to spend time talking about ACS evaluation, which has been a big source of a lot of articles in the past year. ACS testing, rapid rule-out protocols, predictors of ACS, some gender issues that are very important, and we will cover a few EKG topics as we go. If there's any questions that come along, please just raise your hand. I want to make this a little bit interactive, and I probably have more slides than we'll get through. If we get through everything, that's great, but if not, you can get a copy of the slides. Also a reminder, this is not intended to be a journal club, so I'm not going to bore you with p-values and statistics. Largely, I don't understand them anyway, so I'm not going to talk about them. And we're going to talk about some of the key take-home points from each of the articles. There's not a single article I cover which is a perfect article, but there are some important take-home points from what we talk about. Also, at the bottom, you'll see a website there, lectures.umem.org/Mattu. This is on our residency website. I'm going to show this website to you over and over during the course. And what I encourage you to do, the handout is not up to date compared to the slides. So if you go to this website, do not put www first, just lectures.umem.org/Mattu. By next week, you'll be able to download a copy of all the slides we're about to go through, and also any that I don't get to. And it'll be on this website for only a month, all right? So go ahead and download them, and I'll show you that website again. Again, don't put www first. And there's my email at the bottom. I love email. I'm addicted to email. I feel neglected if people don't email me, so feel free to email me any questions, amalmattu@comcast.net, all right? going to start out with the Despair slide. Most of you probably know what Despair is. I love Despair. It's a company that makes spoofs of the success rate photos. And this, I think, is what typifies what my career is all about. The caption at the bottom says, "Mistakes. It could be that the purpose of your life is only to serve as a warning to others." All right? And I'm going to talk about a lot of the cases that I've seen. All these are real cases. Some of these are my own screw-ups. And my hope is that we'll be able to learn from some of my screw-ups and these cases that, in some cases, actually went bad. So let's start out with a clinical question. What's the most important lab test in all of emergency medicine? It's not? Did somebody say D-dimer? Oh. Or just say white count and twist that knife a little bit more. So, all right. Well, we're here to talk about emergency cardiology, so I'm going to argue that it is troponin, okay? And this is kind of my excuse to talk about some very, very important articles that have been recently published about troponin. I'll sprinkle some cases in here. These are typical cases that you see. 55-year-old man with a history of CHF and renal insufficiency presents with shortness of breath, mild chest ache. You get a quick 12-lead ECG, and it just shows LVH and NSJ, non-specific junk, okay? So there's no diagnostic finding there. It's just LVH, and you've seen this case many times before. And he's got an x-ray that's consistent with pulmonary edema. He gets diagnosed with CHF exacerbation, and his troponin is slightly elevated, right? Somebody sent off a troponin. So the question is, does this mean that this guy's also had an acute MI? Does he buy himself a trip to the cath lab or admission to cardiology? And in fact, instead of CHF, you can substitute the same question with sepsis, stroke, renal patients, pericarditis, myocarditis, stroke, a handful of other things as well. Troponin elevations occur oftentimes in our practice through many different scenarios. And so that's why I think it's very important to know troponin, and we have to be the absolute experts in troponin interpretation in our house of medicine. We have to know troponin better than the cardiologist, the intensivist, and anybody else. And there's two outstanding articles that I want to briefly review that have talked about troponin just during the past couple of years as it relates to emergency medicine. So first I'll start out with this graph. And what you'll notice at the top, 1995, that's around the time that troponin first got introduced. And when I was first learning about troponin, and when I and many people in this audience I see first started learning about troponin, we were told that this is the test for diagnosing acute MI. If your troponin is positive, it means the person's having an acute MI. If your troponin is negative, then that's very reassuring and they're probably not having an MI. So I oftentimes would joke that having a positive troponin was like a first-class ticket to the cath lab, or at least to the CCU. Advanced several years, we get to 2003 and then 2007, and we've all seen the sensitivity for troponin rise more and more and more. And what's happened is that the sensitivity for early pickup of acute MI has gotten better and better, and earlier are we able to diagnose acute MI. So it's a great thing to have a troponin that is so sensitive because we can diagnose MI earlier and rule out the cases of non-MI. The drawback is that any time in statistics you increase your sensitivity, what happens to the specificity? It drops like a rock. And we've seen troponin become very, very non-specific. In fact, there's even a newer generation of troponin which has recently been published, and I don't think it's widely available yet in the US. And this was an article from Journal of American College of Cardiology that talked about this super highly sensitive troponin. And a lot of the terms get mixed up. Sometimes people just call it high sensitivity troponin or ultra-sensitive troponin. Bottom line, this is the most advanced troponin that we've now got, and I don't know that it's widely available in the US, but just to show you how sensitive and non-specific it is. In this study, 94% of the chest pain patients that had troponins between 3 and 14 ended up being judged not to have an acute MI. In fact, almost 50% of patients with troponins over 14 turned out to not have an acute MI after they got worked up. So the troponin was great if it was negative, but if the troponin was positive, it left you wondering what to do. It left you wondering, having to get serial troponins. And I don't know if you all have experienced this. I'm guessing you have, but in our shop, our cardiologists know about the poor specificity also, and many times when we get positive troponins, the cardiologist won't take the patients until after a second or third troponin shows that it's rising. So again, I jokingly say that it used to be troponin was a first-class ticket to the cath lab or CCU. Now it's become a standby ticket, at best, after some more serial tests, and that's producing further delays. This is a great article, and you don't have to read everything up here. Don't worry about it. You can pick up the slide later after the conference is done. This is a slide from the Journal of American College of Cardiology article, and it goes through all the different ways that patients can have a positive troponin. And you'll notice up there on the right side, it says ACS, right up there, ACS, STEMI, and non-STEMI. Everything else on this slide represents a non-infarction cause of an elevated troponin. Let me just read these to you. Hypoxia, global ischemia, hypoperfusion, CT surgery, increased demand, hypertension, spasm, coronary embolism, various cardiac procedures, cocaine, methamphetamine, CHF, infection, myocarditis, pericarditis, trauma, ablation procedures, malignancy, stress cardiomyopathy, infiltrative diseases, PE, toxicities from various medications, various types of trauma, renal failure, sepsis, stroke, subarachnoid hemorrhage. And the most recent article that I read, they looked at testing troponins on marathon runners. How many of you run marathons? Don't be afraid. There's psychiatrists outside. Go ahead and raise your hand. So, okay. So marathon runners, triathletes, and ultra-endurance athletes, more than 50% finish the race with a positive troponin. And with follow-up, they all do fine, right? All right? From a heart standpoint, okay? All right? So the specificity of troponin has just become abysmal. And when you send off those troponins, you've got to really think about what exactly you're doing. An elevated troponin in isolation is not that good. And also, you might say, well, if I get an elevated troponin in one of these non-infarction causes, at least it'll give me prognostic information. It turns out that that's true. A patient with PE and a positive troponin will have a worse outcome. A patient with renal failure with a chronically elevated troponin will have a worse long-term outcome. CHF, sepsis, all the rest of them. But it doesn't give you any therapeutic change in management whatsoever. It doesn't change your management. So let's say you get a troponin on a patient with sepsis and it's elevated. Do you treat that patient any differently than the septic patient with the negative troponin? No. Same for stroke, same for subarachnoid hemorrhage, same for pericarditis, myocarditis, renal failure, CHF, and all the rest. There's no therapeutic change. What we really want to know is, when do you have infarction, true ACS, STEMI or non-STEMI, because those are the patients that do need therapy changes. Antiplatelet medications, anticoagulants, maybe cath. All the rest of those, no therapeutic change. So how do you diagnose true ACS? Well, if we can't rely on troponin, what do you do? Well, along comes a bunch of cardiologists. Every 5 years or so, cardiologists all around the world get together and publish the intergalactic definition of myocardial infarction. All right? And this is the third revision of it. All right? ESC is European Society of Cardiology, American Cardiology Foundation, American Heart Association, World Health Foundation. They all get together, and every 5 years, they decide how we diagnose myocardial infarction. And this is something that we need to know. And I'll tell you what the definition is. In order to truly diagnose STEMI or non-STEMI, this is what you need to have. A detection of a rise or fall of cardiac biomarkers, preferably troponin. CKMB is gone. Right? How many of you no longer even send CKMBs in your hospital? Right? Okay. So it's pretty much gone. And at least one of those troponin values has to be at the 99th percentile upper reference limit. And you also have to have one of the following. Clear-cut symptoms of ischemia. So a good story, or a diagnostic EKG, positive imaging, in other words, a positive myocardial perfusion scan, or echo showing regional wall motion abnormality, or identify it at cath or autopsy. All right? And I want to highlight the term rise and fall. Notice that in this in the universal definition, it's not one troponin. It's serial rise or serial fall if you're going to use troponins to diagnose acute MI. It's no longer the single troponin that makes any difference. Right? How much of a rise does it need to be? At least a 20% rise with serial sampling at least 3 to 6 hours apart. Now, with the most advanced generation troponins that we have, you can probably check them every 2 to 3 hours and look for that 20% rise. But the single troponin, unless you have an amazing story and a diagnostic EKG, the single troponin doesn't buy you the definition of STEMI or non-STEMI. You need that second troponin showing a 20% rise above the 99th reference upper reference limit. And this is a quote from the article: relying on a single troponin value should be avoided in favor of serial testing. And serial testing, to me, in my emergency department, means delays. So, what about patients that have some of these other conditions? They will tend to have a more smoldering pattern. Rather than the serial rise, they have an elevation that just stays somewhat elevated. So if you take a look at the top, the middle, myocarditis, CHF, compare that to true myocardial infarction at the bottom. That's the type of rise that you're looking for. At least a 20% rise within those first couple of hours. If you don't get that, then that's not meeting the definition of true myocardial infarction. And that's how you tell the difference between all these other things versus the true STEMI versus the non-STEMI. The bottom line here is that before you go and send off the test, you really need to determine the pre-test likelihood that you're looking at an MI. How many times have you heard people say you need to determine the pre-test likelihood before you send off the test? We've heard that with lactate, we've heard that with D-dimer, you hear it now with troponin. Don't just willy-nilly send off the test, because what that's going to do to you is you're going to end up with those equivocal results. The people upstairs are not going to take that patient until after you get the second test, if you sent the first test and it's elevated. And with the most advanced generation troponin that's on its way, remember that statistic I gave you. 94% of patients with troponins 3 to 14 ended up not having true myocardial infarction. That's how sensitive, in other words, that's how non-specific this test has become. And I love this quote here. This is from a cardiologist who wrote an editorial in Journal of American College of Cardiology. He said, you know, back when troponin was a lousy assay, it was a great test. But now it's becoming a great assay, it's getting to be a lousy test. Right? Very, very true. So my summary for the troponin thus far: it's very nonspecific when sent in isolation. Before you order it, determine the pretest likelihood. And if the pretest likelihood is low and you end up getting a positive test, you're stuck with that patient getting serial levels over the course of the next 2, 4, 6 hours. So don't send the test unless you have a reasonable pretest likelihood or a diagnostic 12-lead EKG. The troponin is very helpful when it's negative, but it's not oftentimes negative with the most advanced generation troponins. Kind of sounds like D-dimer. It's what we're developing. Okay, again, there's to get the set of slides, lectures.umem.org/Mattu. All right, there's some more despair. Just as a little mental refresher here, team building. This is one of the newer ones. Sometimes the most important lesson you can learn is that you're not a very good team. And I love this. I know there's a lot of people in emergency medicine, especially out in this part of the country, that love extreme sports. And I'll just let the caption speak for itself here. So. Questions about troponin before we move forward? All right, let's keep going. Yeah.
Is there yet any place for a single troponin in somebody who's had chest pain for a long period of time?
So the question is, single troponin in somebody who's had chest pain for a long period of time. Let me take that at our next pause, because we're going to talk next about some rapid roulette protocols. All right. So here's another case. 45. Should I stand a certain way for that? All right. Thanks. All right. There is actually no good side. So all right, 45-year-old man presents with chest tightness this morning while at rest. Again, this is another case that I know every one of you has every day. All right, there's no secrets here. All right, and it happened while he was working at his desk. He wasn't doing anything in particular. He had mild shortness of breath, nausea, lightheaded, no sweats, radiation, or vomiting, resolved after 20 minutes. He does smoke about a half pack per day, which we've all learned you double that, right? No other cardiac risk factors. He doesn't have a primary care physician. So you don't honestly know whether he's got high lipid profile or what else. And his physical exam, he might very well have some undiagnosed hypertension. His blood pressure is 150/95. And his exam, top to bottom, pretty much otherwise normal. I'm not hiding anything. Now there's a few concerns up here, right? I don't like the word tightness. When somebody says tightness, I start to worry. Also, if it occurred at rest. The national guidelines say it's more concerning when the pain occurs at rest than when it occurs with exertion, so I don't like that. Shortness of breath, nausea, and lightheaded, I'm worried about all of those associated factors. It lasted about 20 minutes, which makes me worry. In contrast, if he said it lasted for 8 hours continuously, I wouldn't worry that much. If it lasted for 5 seconds or 30 seconds, I wouldn't worry as much. 20 minutes, I'm kind of worried about that. He smokes. That's a concern. He's got no primary, so I don't know whether he's got normal lipids or not. And also, he's probably got some undiagnosed hypertension. So he's got a couple cardiac risk factors there. All right? Now, looking at this case, which I know everybody here sees on a regular basis, I'm going to ask you a question. And there are no wrong answers here, so I'm going to ask everybody to raise their hand for one of these. All right? Number one, would you admit for a workup and essentially turf the risk to the people upstairs? Would you rule them out by enzymes and then send them out for an outpatient stress test in a few days? Would you rule them out and discharge them and you're done? Or would you not even start the workup? EKG, chest x-ray, and you're done. All right? And again, there's no wrong answers here. I just want to get a sense, and I want everyone to see the disparate answers here in this audience. How many people would go for, with this patient, go for number one? Raise your hand up high. All right? How many people go for number two? Rule an MI, get an outpatient stress test. How many people go for number three? Get a few enzymes, it's negative, and you're done. So a handful there. And anyone for number four? You don't just chest x-ray, EKG, and you're done. I've seen that done before. Okay? So why is there so much disparity in terms of how we manage these patients? Right? There's very variable risk in terms of what we're willing to accept. Right? I believe that the current national guidelines are really largely the reason that there is so much disparity in terms of how we manage these patients. All right? And you might not be able to see some of the lettering in the back. Let me just kind of paraphrase what this chart says. This is, by the way, this is from the American Heart Association. This is from Circulation, testing of low-risk patients presenting to the ED with chest pain. This really represents what the current guidelines in emergency cardiology are with regards to managing people that are somewhat low risk. Okay? This is also in the most recent non-STEMI guidelines. In addition to this, and I've seen at depositions, lawyers directly read from this document to the defending physician. And so I think everybody in this room needs to read this document if you're not familiar with it. Because I think this really largely is what the current national standard is. Well, I don't want to say standard. The current national guidelines is. Here's what they say we're supposed to do when you have a patient who's got what you consider chest pain. Let's say you get an EKG and chest x-ray, and it's not clearly a STEMI. What you're supposed to do is to categorize that person into one of three groups. Group number one, this is definitely concerning. Definitely unstable angina. It's a no-brainer. They're going to the cath lab. Or rather, they're going to the CCU. All right? That's the box up here. Group number three, and if you can see this, this is stable angina. We're going to skip that. Group number three, these are patients where I did a history, physical, EKG, chest x-ray. I'm not worried at all. I'm done. You're going home. No further workup necessary. So group number one, those are the real patients that we worry about. Group number three, I'm not worried at all. They're going home. Those are the easy ones, right? Group number two is where it gets really difficult. Group number two is, well, they're not really definite admits, and they're not definite discharge home, so I'm going to go ahead and start sending tests. And that's where you come right down this middle algorithm. And what the middle algorithm here says, you're going to get a 12-lead EKG and get serial enzymes. You can go straight to myocardial perfusion imaging and make a diagnosis, either positive or negative, and call it done. Or what most of us do who don't have myocardial perfusion imaging is you observe the patient with serial EKGs and serial troponins, okay? 2 or 3 sets of troponins over the next 6 or 8 hours. If your serial EKGs and your serial troponins are positive, you move from box 2 to box 1. They're coming in. That's easy. But if your serial EKGs and serial troponins are negative, you don't get to move to box 3, go home, you're done. If your serial EKGs and troponins are negative, the next step in the national algorithm is provocative testing. And that testing can be done right now. It can be done after admission in an OBS unit, or the guidelines say it can be done as an outpatient within 72 hours, quote, within 72 hours, preferably within 24 hours, unquote. All right? So understand this, and this is a very, very important point, which I think is really a large reason that there's so much malpractice on this. People send off 1 or 2 sets of troponins, and then they don't continue following through by getting the provocative test. Now, I know that occurs everywhere. But if you're going to follow the national guidelines, you get your serial EKGs, serial tests. And if they're negative, the next step in the algorithm is provocative test. And if you don't do that, and there's a bad outcome, and it ends up in litigation, I promise you, the plaintiff attorney is going to pull this paper or the other ACCHA papers, and they're going to read it to you at deposition. And they're going to say, doctor, don't you know about these national guidelines? Why did you not follow the national guidelines, this and that? I know a lot of people in here don't follow the national guideline, but I just want you to be aware that if something goes wrong and you haven't followed the national guidelines, one of 2 things is going to happen. Okay, and if you end up in litigation. Number 1, you're going to end up settling because they pull this national guideline on you. Or number 2, if you're lucky, you're going to try to find some literature to back up why you didn't follow the national guideline. And up until 2012, there was no literature to support not following the national guideline. All right? I'll come to you in just a second. Now, I don't think you have to follow national guidelines for high-risk conditions if, and only if, you've got literature to back up why you're not following the national guidelines. Let's take ACLS as an example, all right? I don't follow all of the ACLS guidelines. I think they're flat out wrong in many cases. But there's good literature to say where and why the ACLS guidelines are wrong. And so if you don't follow the ACLS guidelines and you simply pull this literature and say, this is why I didn't follow the national guidelines, good validated studies, you're clear. But thus far, we really don't have good literature that you can pull out and say, this literature, this validated literature is why I didn't follow the national guidelines. Okay? Now understand, this is a risk management issue, but it's a big risk management issue. Missed ACS accounts for more than 20% of all the malpractice dollars we pay out. It's the single biggest cause of money payout in malpractice in emergency medicine. So this is something that you have to understand. Right? And this is the guideline that's going to get pulled on you. All right, now, another disparate, this is the tradition, and the quote down here is, well, just because you've always done it that way doesn't mean it's not incredibly stupid. All right? So even though the tradition is that everybody has to get stress tests, we know inherently that that doesn't make sense. But you need to have literature that says that things don't make sense. And I said, up until 2012, the big problem that we had was that it was very difficult to defend, and I've tried. I've been in a lot of cases on the defense side trying to defend this, and invariably they over and over get settled because there's no good literature to support this, to support not following the guidelines. Well, I think we now finally do have some reasonable literature, and I'm going to argue my own opinion right now that we now have good literature if you follow some of these rapid rule-out protocols that do make this defensible if you follow these guidelines. There's a handful of articles that you see up here, and I'm not going to go through the details of all these articles. You've probably heard about a lot of these things. The 2-hour protocols have the most literature, and I'll talk about the one caveat with regards to that statement in just a second. But there's 3, 4, about 5 articles now that have come out that support these rapid 2-hour protocols using these serial troponins and low-risk features. And what they have found in these studies is that if patients meet this criteria, they have less than a 1% risk of adverse cardiac event by 1 month. And it's generally accepted that if the risk is under 1%, that meets acceptable standards. All right? And so using these protocols, the argument is it's probably acceptable now to discharge patients for outpatient provocative testing or even not, because they have less than a 1% risk at 1 month. Here's what the criteria in these protocols are. And if you're going to use the criteria, you've got to understand, if you're going to use the protocols, you've got to understand what the criteria are. So here's what these protocols say. You have to have a TIMI score of 0. You have to have a fairly unremarkable EKG and troponins that are negative at 0 and 2 hours. It's kind of a no-brainer. All right? So what is a TIMI score? This is what having a TIMI score of 0 requires. You have none of the following: age over 65, 3 or more cardiac risk factors, that doesn't include gender, use of aspirin within the past 7 days, significant known coronary stenosis, severe angina, and that's kind of a problem because that becomes very subjective. If somebody's had more than 2 episodes of pain, 2 or more episodes of pain within the past 24 hours, and it sounds angina-like, that's a point on TIMI, that doesn't meet this protocol. ST segment changes, increased troponin, or CK. We already know that if they've got abnormal EKGs or abnormal markers, they're going to get admitted. All right? So just bear in mind what these troponin protocols are. And I see a lot of people writing, you know what, just again, copy or just download a copy of the PDF of the slides if you want to save yourself that. There's another article that was published in Annals, which is also a really good article that's worth taking a look at. It awaits validation. And Ian Steele was one of the authors of this, and that always increases credibility as well, since he's done some amazing research. And what they found was that if patients had none of the following 5 things: ischemic EKG, history of known coronary disease, typical pain, again, that's subjective. If they had really concerning pain, they're out. Elevated initial or 6-hour troponin, age over 50, it was 100% sensitive for picking up or detecting any potential adverse cardiac events at 1 month. And I think that one problem with this study is that it hasn't been validated yet, but it's a really, really good study, about 3,000 patients, as I recall. So there's a couple of problems here. Number one, the 2-hour troponin rule that I just gave you, unfortunately, has been repeatedly published by kind of the same group of authors down in Australia and New Zealand. And I'd really like to see it republished by other authors in a different part of the world. I think that would really, really nail this home. Nevertheless, I will argue that having 3 separate studies, at least 3 separate studies, really makes this defensible. And then also, that last study by Steele still needs to be validated. All right? Are these now defensible? Again, I'm just going to give you my opinion. I believe that if you follow these protocols and you send somebody home without any further workup, knowing that there's less than a 1% risk by 1 month, I believe that these are now, we finally now have some rapid rule-out protocols that are defensible, which allow you to not have to do the stress test within those first 72 hours. Again, that's my opinion. I'm not a lawyer, but it's something that I think I and a lot of other people would defend you on. If you don't follow these rapid rule-out protocols, at the back of your mind, please know and keep those national guidelines, because they will come back to haunt you if you end up in litigation. And I've seen a dozen cases just like that. All right? Questions about the rapid? Joe, you had a question earlier. Joe asked, if you have 8 hours of continuous pain, and can you get the 1 troponin? All right? And I think that that would reliably rule out infarction, but you'd still need to go down that provocative testing pathway in order to meet national guidelines. Again, and again, I didn't put this in the slide, but I think this is a really important point for everybody to remember. Please remember troponins. When we use troponins for MI, we're talking about infarction. Troponins are not always reliable for ischemia. And the patients that we're missing and getting sued for are not the missed MIs. We're getting sued for missed unstable anginas, and those patients typically have negative troponins. All right? Yes, question?
I understand your concern about not having evidence to not follow the guidelines, or there being a lack of validated evidence. Is there evidence that following the guidelines results in lower morbidity and mortality by getting that proof from studies?
Sure. Okay, so the question is, has following the guidelines been shown to improve morbidity and mortality? I can't quote you a study. What I would say is that the guidelines are so conservative that if you follow the guidelines, then it probably will decrease morbidity and mortality from really tiny to even less.
Well, my concern is the potential of the falsely positive.
Okay, so, and that's a great question. The question is, what about the false positives? There's harm associated with false positives that nobody really talks about. It's a great question. Are these patients going for unnecessary cath? Yes, they are. Are these patients in some cases even going for unnecessary bypass? The answer is yes, patients have gone for unnecessary bypass for these type of reasons. But nobody talks about that. And until people start incorporating that into the decision-making rule, I'm not really sure that that is a valid risk management argument. And I highlight risk management. This is a risk management issue, okay? If you talk to your patient and explain the possibility of false positives and the risk associated with that, and they're on board with not getting the test, I think that's fine. But from a risk management standpoint, and that's all I'm trying to focus on, the risk of litigation, the risk management issue, nobody's really addressed that in any guidelines or any papers sufficiently, the risk of false positive stress testing, false positive other types of tests as well. Yep, question?
Can you explain your rationale or decision of immediate versus delayed within 72 hours provocative testing?
So the question is, can I explain my reasoning? I'm just quoting the guidelines. The guidelines specifically say that if they meet these low-risk criteria, if they have normal EKGs, normal troponins, if you can get them an outpatient stress test within 72 hours, that's fine. That's what the guidelines say. So that's not me saying it. I'm just quoting what the guidelines say. Yeah.
So how can you assure that they get that stress test? Do you have to set it up yourself?
That's a good question. So the question is, how can you assure that they get the 72-hour stress test? You have to set it up yourself. And that's a good question. If you can't assure it in some way, then I think you're stuck. In our hospital, inner city, we can't assure that, and so we oftentimes have a lower threshold for admitting these patients. If you can get it set up, if they've got a primary who can hook them up, if they're in some type of insurance system, like a Kaiser system that can get them early follow-up, then I think that works out very nicely. If you can't assure it, then you're kind of walking on thin ice. Let me take one more question, and then we'll move on. I'll be around if there's any other questions. Yeah. So if the patient has an outpatient stress test that's negative, and then they come back with the same symptoms, I would say probably you don't need to repeat it. On the other hand, if they come back with a different set of symptoms, then you need to worry. And I'd refer you back to a lecture on the utility of outpatient stress testing that we did a couple of years ago, which is on EMedHome. So, all right, let's keep moving on. And if we have time at the end, we'll take a bunch more questions also. All right, a little more despair. These are amongst my favorite. Kind of makes me want to go running. The quote here is, defeat, for every winner there's dozens of losers. Odds are you're one of them. And then this one, this really makes me want to go running. And the caption here is, it's over, man, let her go. Okay. Let's keep marching. Okay, back to that case. 45-year-old man presents with chest tightness this morning while at rest. Mild shortness of breath, nausea, lightheaded. No sweats, radiation, vomiting, resolved after 20 minutes. Now he's asymptomatic. Whoop. And let me throw in also, he says, it feels like my previous MI. All right. Now, let me ask. All right. How many people would admit this guy? All right, everybody. How many people would rule him out and then get the outpatient stress test? In 24 hours? 12 hours? No. Should I even ask about 3? Oh, so everybody's admitting that patient. That's interesting. Okay, I certainly would as well. Patient was admitted and ended up ruling out completely negative for ACS. Is that a surprise to anyone? Right? We've all had patients that we're really worried about. They get admitted and it ends up being nothing. Right? We've all had that. And yet these are all factors that we've thought are definitely ACS. Yeah, question? Okay, so the question is, how many people have tried to admit that patient and gotten resistance? Everybody, right? Yeah. So next year, just invite them to the lecture. Okay, so presentations have actually been studied since back in 98. In 2006, here at AAM, we reviewed that 2005 article. In 2011, we reviewed that 2010 article. And yet another article has come out. And what people have done is they've taken a look at all the symptoms that we were taught to worry about. Chest pressure, tightness, radiation to my neck, my jaw, squeezing, lightheadedness, shortness of breath. everything. They've looked at, it's just like my previous MI, and they've identified which of those factors are likely to rule that patient in for ACS and which of the factors are likely to end up ruling out for ACS. And it's a bit surprising, all right? Summary, pressure, tightness, squeezing. I learned to worry about that. Pain occurring at rest. They say it's like my previous ischemia or heart attack. I worry about that. Associated shortness of breath, associated lightheadedness, nausea, and 4 major studies have come out and said none of those predict whether the person is going to rule in or rule out. They are completely nonspecific. And if you think about it for a second, that's not a surprise to anyone here. Because you have all, and I have certainly had patients that I'm really worried about the history, and they rule out entirely. Kind of makes you wonder, well, what's reliable? It's actually very simple. So these 4 studies have identified some common themes. There are only 4 factors that are associated with reducing the likelihood that that chest pain patient in front of you is going to rule out. All right? Pain described as pleuritic, sharp, reproducible, or positional. All right? Now notice that that decreases the likelihood, but it doesn't rule it out. Nothing risk stratifies to 0, so there's still some risk. But if you can get any of these 4 on the chart of somebody who's going home, it's golden, because it really reduces, it should reduce your concern and also more defensible. There's only 4 factors of everything that we've learned, the only 4 factors that have been consistently identified to increase the risk of ACS, to increase the likelihood ratio that that person will rule in for ACS are pain that radiates, and pain that radiates to the left is the least useful. In fact, there's 1 or 2 studies that say if pain radiates to the left, it means nothing. Pain that radiates to the right is far more concerning than radiates to the left, and worst of all is if it radiates bilateral. What I would say is if it radiates anywhere, you worry about it. Pain associated with diaphoresis, especially if they are diaphoretic in front of you. Pain with exertion and pain with vomiting. Not nausea, but pain with vomiting. That's been a consistent finding in the 4 studies. The 4 most concerning things are pain that radiates, pain with diaphoresis, pain with exertion, pain with vomiting. So simple take-home points from these 4 articles. If the patient has chest pain with radiation, diaphoresis, exertion, or vomiting, you've got to worry, and you better really think twice, think 3 times before you ever send that person home with any of these 4 factors. Take-home point number 2, if you're considering discharging that patient home, make sure that they don't have any of those top 4 and try to document some of those bottom 4. All right? Just document it. Who cares? All right? No. For the record, I'm not encouraging lying on the chart. But try to document those on the chart if you're thinking about sending them home, and make sure that you can document absence of those top 4. 4 major studies, including 2 from JAMA, that have come out and said exactly what you need to document on your chart. And this is enormously defensible. All right? So let's sum up once again. Troponin, D-dimer of the 2000s. Rapid rule-out protocols are, in my opinion, becoming defensible. Make sure you use them properly, though. And things you got to worry about, radiation, diaphoresis, pain with exertion, pain with vomiting, and things that you need to document if you're going to send somebody home, that it was pleuritic, sharp, reproducible, positional. Of course, you want to think about PE and other things. We're only talking about ACS here. All right? These are 8 factors that you need to ask every patient and document on every chart. All right. Let's keep moving. All right. Some people have created their own despair ones, and these are some of the fun ones. Girl Scouts, you know what? Next time, just buy the damn cookies. I love that. All right. Okay. Let's back to this case. What's that? Okay. Back to the case. 45-year-old man, same case, with chest tightness, AM while at rest, mild shortness of breath, nausea, lightheaded, no sweats, radiation, and so on. Let me change a few things here. Instead of a 45-year-old man, let's make it a 35-year-old woman. Instead of lightheadedness, she's got severe malaise. All right? She does have a primary. Like, women are a lot better than guys about having primary care docs. And with these primary care visits, no real medical problems. Although she does smoke. She's premenopausal, and she's got a bit of hypertension. All right? So consider this for a second, and let me ask you this now. All right, question. In the 45-year-old man case versus the 35-year-old woman case, you've got them in adjoining rooms. Let me ask you this. All right, which patient's more likely to rule in, the man or the woman? How many people say the man's more likely to rule in? How many people say the woman's more likely to rule in? How many people are just going to go see the ankle pain instead? All right. Which patient's more likely to be missed if they are having an MI? The man? The woman? Everyone. Okay. Actually, just on this side of the room. Let me come over here. Okay. All right. Which patient, if admitted, is more likely to die? How many people say the man? How many people say the woman? All right, more people. 35-year-old woman against a 45-year-old man, right? Those are 10 tough years between 35 and 45. All right? Okay. So this is a really, really great article. It's from JAMA. It's kind of medicine-y, but I think for the emergency physician, for all of us, there are some really, really useful take-home points. I love this article because it's very simple, and the take-home points save lives. I promise you, if you remember what's in this article, it will save lives. And it'll decrease litigation. A lot of people in here, I'm sure, do medical legal work, and what I'll tell you is in the past 5 years, I have seen on an order of probably 5 to 1 more lawsuits for missed ACS and MI in women than in men. And this is a fantastic article, and if the people that were involved in those lawsuits knew what was in this article, I would say it would have gotten rid of all of those lawsuits. Because every one of them was a young woman who had an MI and died. All right? In fact, I've never seen a lawsuit for an older woman who had an MI and died. All of the cases, and I'm sure there's some spectrum bias in there, but all of the cases that I see are young women who had MI and died. And I think we've been taught a myth that women just don't have MIs at younger ages. All right. In this study, Canto studied the relationship of age and sex, presence or absence of chest pain at arrival, and also the above factors on hospital survival. And we'll go through this really quick. This is a very large registry of MIs, over 1 million patients. So all of the subgroups had tens of thousands of patients. Huge, huge study. All right. And again, all of these were MI. 42% were women. So just a couple of key findings, and we'll move on. Key finding, this is for all comers. Number one, 50% of patients over 75 had no chest pain. All right, so just a simple reminder. I think most faculty and most attendings in here know this. For the residents that are here, please don't rely on chest pain in older patients. 50% of patients will not have chest pain over the age of 75. They'll have other symptoms, shortness of breath, weakness, lightheadedness, and so on. All right. Now, the bottom statement up there was a surprise to me. I thought, and I learned, that as you get older, the difference in presentations between men and women starts separating. And elderly women have very different presentations than elderly men. Not true. The major differences in presentations are in young women, not the elderly women. And with regards to just looking at young patients under the age of 44, and don't want anyone to be offended by their use of 45. I'm in the elder group here now, apparently. So in patients under the age of 45, key findings worth noting, almost 20% of women with an MI had no chest pain. And this was foreign to me also. I figured young men, young women, they're all going to have chest pain. 20% of women didn't. And in fact, 13% of the men under 45 had no chest pain when they had their MI. Another key point. Young women had a slightly higher in-hospital mortality than young men, but even more than that, if the young women had no chest pain, the mortality was much greater. 15% in-hospital mortality in young women with no chest pain. When was the last time you saw any study which quoted a 15% mortality in young people? 15 versus 10%. Young women have a much higher mortality, even in the pain-free state. And in fact, Cantor did a study back in 2000 where he looked at all comers in MI. In general, patients without pain have a much higher mortality. And again, these are not misdiagnosed patients. These are patients diagnosed with MI and admitted. So nothing was missed. The painless presentations that get admitted have a much higher mortality than the chest pain presentations that get admitted. So don't ever lower your concern just because somebody had no chest pain. Simple take-home points again from this article. Please remember, young women do have MIs. And that's not something that I learned when I was in residency. I learned it's a male condition over the age of 50, and in women, you got to be 55, 60, 65. Young women do have MIs. They tend to present very atypically, much more so compared to men than the older women when you compare the differences there. And they also have a much higher mortality, very high risk, and painless presentations are very, very high risk. Be on the lookout for those patients. All right, so summary thus far. Troponin, the white count of the 2000s. Consider using rapid rule-out protocols, radiation, sweat, pain with exertion, vomiting. You've got to worry about that. Young women do have MIs. Beware of painless presentations, and beware of severe malaise. It's a very common presentation. Shortness of breath and severe malaise in women, not just the older women, but the young women also. Get a 12-lead EKG. Right? How many women here are feeling tired? I don't want to know. Okay. All right. So again, lectures.umem.org/Mattu. We've got about, Mike, about 8 minutes or so? Let's do one more. All right? To do one brave thing today, then run like hell. I love this. You need to look at this and just think about it for just a moment. This could be in Vegas, by the way. Okay. Let's talk about EKGs for just a second. We've got to get some EKG stuff here. You know, Dr. Donner sent this to me from his health club. He took this picture. You know, she needs to get off that treadmill. She's having a big STEMI, for gosh sakes. All right. 58-year-old man presents to the ED complaining of chest pain, nausea, shortness of breath. All right, uncomfortable, normal cardiopulmonary exam, and here's your 12-lead EKG. All right, it's a left bundle. Left bundle branch block pattern. And the last time we got an EKG on it was 6 months ago. It was normal. Presumed new left bundle branch block pattern. What do you do with that? You got to call cardiology and send them to the cath lab or give them lytics. Chest pain with the presumed new left bundle is considered a STEMI equivalent. Activate the cath lab. All right? So let's just go back to the basics for a second. Which patients with chest pain need emergent reperfusion? Patients have to have chest pain plus concerning symptoms, or concerning plus an EKG. What are the EKG criteria? Well, we've all learned this. This is in the national guidelines. You need to have ST elevation in 2 contiguous leads, or a posterior STEMI, or a new left bundle, or a left bundle with Sgarbossa criteria. And we're not going to get into Sgarbossa criteria too much right now. All right? But I want to talk about this concept of the new left bundle because this is changing. There's a handful of articles that have been published that we reviewed in previous years indicating that patients with the new chest pain plus new left bundle is not more likely to rule in than chest pain plus known old left bundle versus chest pain and no bundle. They all rule in at the same rate. So where did this concept come from that new left bundle equals MI? Well, it was discussed in detail, and I'm not going to go through those details of the history here, but this was a fantastic article published in the Journal of the American College of Cardiology that if your cardiologists don't know about, you need to give them this article. It's a wonderful review article about this concept of new left bundle. And they went through a handful of things, and essentially what they said was that this concept that we all have that's still in the national guidelines of new left bundle equals reperfusion, cath or lytics, comes from very, very poor data. There's a lot of data dredging and extrapolation. And it's also based on the assumption that when somebody's got a left bundle, you can't tell whether they've got ischemia, right? Left bundle means you can't read anything. And what we now know is that that's not entirely true. In this article, essentially what they said was that a left bundle should only be considered a STEMI if one of two things is happening. Number one, if the patient's unstable. So if they've got a new left bundle and they're unstable, call it a STEMI. All right? Or if they've got a new left bundle with Sgarbossa criteria, call it a STEMI. If they're not unstable and they don't have Sgarbossa, it's not likely to be an MI. And the reason is very simple. If somebody has an MI that causes a new left bundle, it implies an infarction that is so large that the patient will have to be unstable. You're not going to have an MI with a new left bundle and just be sitting there chilling in the stretcher. All right? You're going to be unstable, or at the very least have good Sgarbossa criteria. And again, this is from their journal, so it's worth knowing. This is a normal left bundle. Just to remind you what Sgarbossa criteria are. The two criteria from Sgarbossa they talked about, if somebody has ST elevation in the same direction of the QRS, or if somebody has ST depression in the same direction as the QRS in V1, V2, or V3, that represents what I refer to as Sgarbossa A and Sgarbossa B. All right? And this is a very nice algorithm that they put in their journal. All right? And if you can't see it from the back, that's fine. Essentially what they say is very simple. Somebody's got suspected ACS, so they have to have symptoms first of all, right? They have to have a pretest probability based on their symptoms. If they're unstable, they go right for cath. You're done. Left bundle plus unstable, you're done. Don't look any further. If they're not unstable, now look at the EKG. No, look a little bit more at the EKG, I should say. And if they have a left bundle plus Sgarbossa A or Sgarbossa B, then they go right to the cath lab, right out of their main journal. All right? And so how many of you have had the experience of calling up your cardiologist for a new left bundle and they say, no, I'm not going to take them to the cath lab? Anyone? Right? So I presented this to our cardiologists and said, hey, the new the guidelines are wrong. They said, oh, we knew that already. I said, what? These are your guidelines. These are your national journals. Your guidelines say new left bundle equals MI. And they said, oh, we never read that stuff. I kind of knew that already. But they've never followed that. And this is why. Because they knew that if you have an MI causing a new left bundle, you're going to be unstable. But I think it's nice to see the Sgarbossa criteria in there as well. If somebody's got those Sgarbossa criteria, their journal says that justifies a trip to the cath lab. So show that to your cardiologist. And also, talk to your cardiologist ahead of time. Don't wait till it's 2 o'clock in the morning before you start asking them, do you want to take this patient or not? Ask them ahead of time. Do you guys normally take new left bundle to the cath lab? And if they say yes, well, fine. But show them this article, which says that they're not likely to rule in unless they're unstable or unless they've got Sgarbossa criteria. So, quick take-home points. New left bundle in the absence of hemodynamic instability or in the absence of Sgarbossa are unlikely to be a STEM equivalent, and those guidelines are going to be changing in the coming years. Talk to your cardiologist about that. All right? So, why don't we just wrap it up here? And again, there's a few things that we didn't cover that you can just download in the slides a little bit later on. All right? Troponin, I'm probably leaking some right now. That's how nonspecific this thing is. All right. Consider using rapid rule-out protocols. Radiation, sweat, with chest pain with exertion, vomiting, you've got to worry about that. Beware women with malaise. Tired women, just get the 12-lead EKG. Those are the cases that we're missing. Those are the cases which consistently show up in litigation. The painless young women who have MIs, and they die because they have a higher mortality when they have painless presentations. All right? And new left bundle plus chest pain is not an MI unless they're really sick or unless they have those Sgarbossa criteria. All right? So, with that, I will conclude. I want to thank you all very much for your attention. I'll stick around up here if you have any questions. Thanks a lot.